Very much, Gabrielle. Last but not least, we have Amanda McClelland from Resolve to Save Lives, who has extensive experience contributing to building capacity at community level and at national level across a number of outbreaks. And she'll be giving us an international perspective on building national level capacities. Amanda, over to you.
Thank you so much. I have to admit, normally I'm on these panels because I've spent the last 14 years working with the Red Cross at community level, working at the interface between communities and health systems. In the last 12 months, I've switched and tried to work from the health system and get that to engage in the communities. And so my key talking points as a nurse from the community level is always communities are important and infection prevention control in healthcare workers is critical. That message must have been picked up because all of the speakers so far today have made those points, which leaves me kind of a redundant point that we've been hammering on for the last few years. So I'm really glad to see that permeating and the key points recognised of the importance of early detection, early communication, community engagement and working with our healthcare workers are so critical. So maybe I take the opportunity today to shift the conversation to the next stage where after years of trying to get communities and communities at the centre, I've realised that perhaps the biggest lesson is not that capacity building and the course of epidemics sits with healthcare workers or communities, but unfortunately with politicians. And I think the more I work at country level and the more I work with governments, we and the three fellow speakers have really made the point, we're using crisis to build capacity. We're waiting for large events, the silver lining of Ebola, to build capacity with this constant panic and neglect cycle where public health workers sit on the sidelines waiting for a crisis to occur so that we can do what we already know and what we've known for many, many years needs to be done. So what do we as a group do to move from that cycle? How do we engage our politicians and our communities to make sure that we cannot just sit here and again speak about the lessons learnt epidemic after epidemic, but how can we make sure that we're more ready for those epidemics before we get these large crises? And I think the main takeaways for me in terms of my new role where we're trying to support at country level with WHO, CDC and many other partners to implement the JEEs you mentioned, accountable measures of capacity, is how complex epidemic preparedness is and how difficult it is to explain in its entirety to politicians and even other departments within ministries. The JEE contains 19 technical areas and 54 indicators. Some of the national action plans that have been developed have over 400 priority actions for the first year. As a program manager in a low-resource country, it's almost impossible to coordinate 6 ministries over 200 or 300 priority actions. So how do we support countries that have so far to go, that don't necessarily have the political buy-in, don't necessarily have the full financial resources to build such complex systems to ensure that their IHR are ready? And I think from Resolve's perspective, we'd like to see a narrowing of the capacities or a prioritisation to core tasks that really are focused on making sure that the countries have the ability that Dr. Fala mentioned, that they're able to detect, they're able to respond, they're able to prevent where they can, and they're able to communicate and work with their communities effectively. So within the JEE, we've been working with a number of countries to help try to prioritise from those 400 priority actions down to a set of 50 that are really focused in 7 of the 19 technical areas within the JEE. So we've been focusing mainly on response, surveillance, lab, health workforce, and then really using legal and finance, preparedness and risk communications to lever those. We've found the legal and finance indicators within the JEE are a barrier to move forward. If countries don't have the mandate to declare emergencies, it's very difficult to generate the funds and to have politicians going. We found that the more countries improve, the more difficult it is to explain to politicians. A good example, I was recently in Uganda, where the president of the country questioned the effectiveness of the Ugandan team because they were declaring an outbreak almost every week. This was because of improved detection, but politically it didn't sit well that they were declaring anthrax and Rift Valley fever and a number of other high-profile diseases. So as we build the capacity to detect, we also need to build the capacity to report and support those politicians and policy advisors to manage those communications and those declarations. So I think the focus, the other challenge of working within the JEEs and the IHR is that there's a number of components missing. The JEE is not a perfect tool. It's a great tool. It's the tool that we have, but it's been tasked and created very much to make sure that countries are able to be IHR compliant. And I think there's an ability to perhaps step back in the coming year to see if IHR compliance equals epidemic preparedness. And what are the other capacities that are missing within the JEE that are critical to prevention and detection? And my colleagues have mentioned some of those today. The frontline healthcare worker and the IPC component is difficult to find within the JEE. IPC is buried within AMR. Frontline healthcare workers and their training is a new addition in JEE 2.0. And we've heard how critical they are in early detection and early response. And so what else can we do to support those frontline healthcare workers? Not just to be able to detect and respond, but to engage with those communities. And I think DRC Ebola outbreak is a great example of we can't always rely on international response or regional response to be able to access an area, and empowering community health workers and frontline health workers to be able to deliver epidemic care is increasingly important, especially in those conflict or hard to reach areas. The other aspect that's very difficult to see within the JEE is communities and the role of civil society and how governments engage with other partners outside of the core partners that we've heard mentioned today a number of times. So how do we work within the structure of the JEE, make sure that we build those core capacities, but ensure that we're not losing some of the key lessons around politics, around communities, and around financing that's important to ensure those capacities are effective, not just for the crises, but for every epidemic.
Great.